Hello NCLEX students, welcome to this audiobook, your ultimate passport to passing the NCLEX exam on your very first try. We've carefully crafted this resource to include all the most important topics that the boards love to test year after year. This isn't just another study guide. It's a focused, high-yield resource designed to maximize your chances of success. Stay tuned until the very end because we've included only the most repeatedly asked exam-relevant content to ensure you're fully prepared. So sit back, listen, and let this audiobook guide you to NCLEX success. Now we're diving into one of the most critical topics to help you crush the NCLEX and become rock solid in your nursing practice, legal and ethical nursing principles. This isn't just exam material, it's your guide to navigating real-life challenges in healthcare. Stick with me because I'll be dropping plenty of NCLEX tips, must-know scenarios, and examples to make these concepts stick. Ready? Let's roll! Negligence and malpractice. Let's kick this off with a scenario. Imagine you're on a crazy busy shift, juggling meds, charting, and a demanding patient load. You accidentally miss a critical assessment. Could this be negligence? Let's break it down. Negligence happens when your actions, or lack of actions, fall below the standard of care. Commission, doing something wrong. Omission, failing to do something you should have. Here's the deal. The NCLEX loves these scenarios. A nurse who doesn't meet the standards may be held liable for negligence, so keep that in mind when you see questions about errors during care. Now let's talk about malpractice, which is negligence by a professional nurse. Here's how it's determined. Duty. There's a clear nurse-patient relationship. Breach of duty. The nurse didn't meet the standard of care. Proximate cause. That breach caused harm. Injury. The patient suffered because of it. NCLEX alert. You'll likely see questions where you'll need to identify which step of liability was breached in a scenario. These details are gold. Know them cold. Professional liability insurance. Here's a quick question for you. Should you get your own professional liability insurance? Absolutely, yes. Let me tell you why. It protects you in case of a lawsuit. You'll have an attorney dedicated to your interests, not just your employer's. This is a practical point NCLEX might test. If it's in the question bank, you'll be ready. Good Samaritan laws. Imagine this. You're off duty and see someone collapse. Do you help? Yes, because Good Samaritan laws protect you. Here's how. These laws offer legal immunity if you provide reasonable care during an emergency. To qualify, you must avoid intentional negligence and can accept payment. NCLEX. Tip. Questions here often focus on the conditions under which Good Samaritan laws apply. Controlled substances. Now, let's talk about those locked cabinets. Controlled substances. These are hot NCLEX topics, so listen up. Next, follow your facility's policies to the letter, keep meds securely locked and signed out accurately. Here's a common NCLEX scenario. What do you do if a medication goes missing? The focus will be on proper documentation and inventory management. Don't let this trip you up. Collective bargaining. This might seem less clinical, but collective bargaining impacts nursing practice too. This is the negotiation process that determines wages and work conditions. Now, here's the tricky part. What happens during a strike? Ethical dilemmas arise because our profession is centered on serving others. NCLEX loves questions that ask you to balance ethical considerations in situations like these. Legal risk areas. Okay, this is a big one. Listen closely. These are legal risks every nurse must know. You'll see these concepts pop up a lot on the NCLEX. Assault. Threatening harm without physical contact. Battery. Intentional, unauthorized touching. Even giving an unwarranted injection. Invasion of privacy. Sharing client information without consent. False imprisonment. Detaining a client without legal justification, like improper use of restraints. Defamation. Damaging someone's reputation through false statements. Fraud. Deliberate deception for unlawful gain. NCLEX. Hotspot. Pay special attention to scenarios involving restraints and confidentiality breaches. These are exam favorites. Client rights. Every client has the right to participate in their care. Let's talk about what you need to know for the exam. The client's Bill of Rights emphasizes autonomy and informed decision-making. Many NCLEX questions will test your knowledge of client consent. SWOI. Consents. Know them cold. Here are the types of consents you must know for the NCLEX. Admission Agreement. Signed at admission. Outlines responsibilities. Immunization consent. Highlights vaccine risks and benefits. Blood transfusion. Consent. Critical for clients with religious restrictions. Surgical consent. Obtained by the physician performing the procedure, not the nurse. Research consent. For studies, clients must understand risks and benefits. Special consents. For things like restraints, organ donation, or photography. Here's the golden rule. Consent must be signed freely, without sedation, and with full understanding. If the client is confused or has questions, it's the physician's responsibility to clarify, not yours. Keep that in mind. NCLEX Insight. Be ready for questions about exceptions, like emergencies where consent is waived. Minors and emancipated minors. Let's wrap up with an important topic. Minors and their ability to consent. Typically, minors can't provide consent, but there are exceptions. These include emergencies, substance abuse treatment, STD treatment, birth control and pregnancy care, and don't forget, emancipated minors can consent independently. The NCLEX loves scenarios like these, so be sure to review them. All right, class, buckle up, because now we're diving into advanced directives and reporting responsibilities, two essential topics that you must master for the NCLEX. Why? Because these concepts are exam favorites. So grab your pens and highlighters and let's make this session unforgettable. Advanced directives, your right to choose. Let's start with a scenario. Imagine you're unable to make decisions about your own health. Scary, right? But wouldn't you want a plan in place to make sure your wishes are respected? That's exactly what advanced directives are for, and they're rooted in something called the Patient Self-Determination Act. This law empowers patients with the right to decide their future care, giving them control even when they can't speak for themselves. Here's what you need to know. Key points about advanced directives. When a patient is admitted to a healthcare facility, the first thing we ask is, do you have an advanced directive? If they do, it gets documented in their medical record. If they don't, no problem. They can create one right there. Two types of advanced directives. Know these for the NCLEX. Instructional directives. Think of these as a patient's wish list. They specify treatments they want to avoid if they're terminally ill. For example, no feeding tubes or no ventilators. Durable power of attorney for healthcare. Here's where a patient picks their healthcare proxy, a trusted person who will make decisions for them when they can't. NCLEX tip. Questions on these two types appear all the time. Know the difference and be ready for scenarios where families or proxies must decide. DNR prescriptions. Do not resuscitate. Let's talk about DNRs. Picture this. A patient decides they don't want CPR if their heart stops. That's when a DNR prescription comes into play, written and formalized by their primary healthcare provider, PHCP. Here's what you need to remember. Informed consent is key. The client or their legal representative must agree to the DNR. It's not a blanket refusal of care. DNR applies only to CPR. Other treatments like oxygen or pain management can still continue unless specified otherwise. Protocols differ by state, so know the guidelines where you're practicing. Quick quiz time. What happens if a client's DNR status isn't clear in their medical record? Answer. Healthcare providers must make every effort to revive the patient. This is a high-stakes NCLEX question that trips up many test takers, so lock this in your memory. The nurse's role in advanced directives. Now, here's where you as nurses shine. You're not just caregivers, you're advocates. Your role in advanced directives is critical, and here's how you can excel. Start conversations about advanced directives. Help patients think through what promotes quality of life versus prolonging suffering. Ensure advanced directives are documented and that the PHCP is aware. If it's not in the record, it's as if it doesn't exist. Follow directives to the letter to avoid liability. But also, know your facility's policies, especially if you're asked to witness legal documents. Key takeaway: patients trust you to safeguard their wishes. Advocacy isn't just a buzzword, it's your superpower. Reporting responsibilities. All right, let's shift gears. Next up is reporting responsibilities, another area where NCLEX loves to test you. Let's start with a pop quiz. What should you do if you suspect a coworker is impaired and it's affecting patient safety? Correct answer: report it to your supervisor immediately. Here's why. Patient safety always comes first. From there, the nursing administration will notify the Board of Nursing, conduct drug tests if necessary, and handle the situation. As nurses, you're legally and ethically obligated to act if you notice unsafe practices. Other key NCLEX topics. Let's hit some hot topics you need to know. OSHA regulations. Employers must provide a safe workplace. If you notice violations, you can report them confidentially. Sexual harassment. This includes any unwelcome conduct of a sexual nature. Know your agency's reporting process and follow it to the letter. Leadership, delegation, and professional responsibilities. Welcome, future nurses. This is your ultimate guide to mastering NCLEX questions on leadership, delegation, and professional responsibilities. What we're covering now isn't just theory. It's your passport to acing the exam and stepping confidently into your nursing career. So grab your pens, stay sharp, and let's make sure you leave today feeling unstoppable. Prioritizing client care, leadership, delegation, and emergency response planning. Professional responsibilities. Let's start with a core concept you must know for the NCLEX: accountability. It's not just a buzzword, it's the foundation of nursing practice. Let me break it down for you. What is accountability? It's your duty to act, make decisions, and take full responsibility for their outcomes. Always stay within your scope of practice. If you're not trained for a task, don't attempt it. If mistakes happen, and yes, they will, own them. Admitting errors isn't just ethical, it's what NCLEX tests. NCLEX tip: remember this, if the question asks, who is responsible for a nursing error? The answer is always you. Accountability is about more than doing tasks. It's about ensuring every action aligns with your client's well-being and ethical standards. Leadership and management. Let's shift gears to leadership and management. What's the difference? Leadership is about inspiring others to achieve goals. Management is about organizing resources to get things done. Both are essential in nursing practice. And NCLEX loves to test your understanding of how these roles play out in real-life scenarios. Theories of leadership and management. Now, let's unpack leadership theories. These might sound theoretical, but they directly tie to how nurses operate in the real world. Charismatic leadership inspires others through personal charm and belief systems. Quantum leadership thrives in chaotic environments by balancing order and creativity. Relational leadership focuses on collaboration and teamwork, perfect for healthcare settings. Servant leadership puts others first, prioritizing the needs of clients and team members. Shared leadership spreads responsibility across the team, encouraging collective decision-making. Transactional leadership relies on rewards and punishments to motivate. Transformational leadership, the gold standard. This leader inspires change and builds strong relationships. NCLEX tip: expect questions highlighting transformational leadership as it reflects modern nursing values. Leadership styles. Next, let's explore leadership styles. These are critical for understanding how to approach various nursing scenarios: authoritarian, direct, decisive, and my way or the highway. Ideal in emergencies like code blues, but not for fostering long-term collaboration. Democratic encourages input but ensures the leader makes the final call. Great for promoting trust and teamwork. Laissez-faire, a hands-off approach. It fosters independence but can lead to confusion without strong team dynamics. Situational. Adapts to the needs of the moment. Think of it as flexible and responsive. Bureaucratic. Relies heavily on rules and policies, provides structure, but may feel overly rigid. NCLEX. Tip. Leadership-style questions are situational. For example, in a crisis, authoritarian leadership works best. For long-term projects, democratic leadership is ideal. Types of managers. Now let's talk about managers. NCLEX frequently tests your understanding of who does what in a healthcare setting. Frontline managers includes charge nurses and team leaders. They supervise client care directly. Middle managers. Think unit managers. They handle staffing, budgets, and maintaining care quality. Nurse executives. High-level roles like directors of nursing. They collaborate with administration to set organizational goals. Exam. Highlight. If the question is about daily staffing, think middle manager. If it's about shaping long-term vision, that's a nurse executive. Power and empowerment. Let's talk about power and empowerment, two buzzwords you'll see in leadership questions. Power, it's the ability to influence others positively. Great leaders use their power to inspire change. Empowerment, it's about enabling others to make decisions and take ownership. You empower clients by educating them and involving them in their care planning. NCLEX tip, look out for questions about empowering clients, for example, teaching them self-care skills or including them in care decisions. Formal organizations. Finally, let's tackle how healthcare organizations are structured. This might seem dry, but it's vital for delegation and planning questions. Mission statement defines the organization's purpose and core values, goals and objectives, measurable outcomes that drive the organization's programs. Organizational chart, a visual representation of hierarchy, who reports to whom, policies, procedures, and protocols. Policies set the rules. Procedures explain the steps. Protocols are specific to conditions or emergencies. Centralization versus decentralization. Centralization means decisions come from top management. Decentralization brings decision-making closer to the client, enabling faster and more client-centered care. All right, class, let's get real. Topics are some of the most high-yield, exam-critical concepts for your NCLEX. If you master these, you'll be ahead of the curve. We're talking delegation, assignments, time management, and prioritizing care. Stick with me because not only will I give you insider tips, but I'll also break it all down so it's easy to remember. Ready? Let's go! Delegation, the art of smart nursing. Picture this. You're on a busy shift, alarms are going off, patients are calling, and it feels like the sky is falling. Sound familiar? Delegation is your lifeline. But delegation isn't just tossing tasks to anyone. It's a skill, a strategy, and it could be the difference between safe patient care and chaos. So what is delegation? It's assigning tasks to someone who's both competent and authorized to perform them. Here's the twist. You are still accountable for the outcome. That means if you delegate wound care or vital signs, you need to follow up to make sure it's done right. Let's clear something up with an example. Can a CNA assess a patient's pain? Nope. Assessment is always the RN's job. Questions like this love to pop up on NCLEX, so know your boundaries. The 5 rights of delegation. Okay, everyone, say this with me. Right task, right circumstance, right person, right direction, communication, and right supervision, evaluation. These are the 5 rights of delegation, and they're your golden rules. Let's break them down. Right task. Is the task something you can delegate? Right. Circumstance. Is it safe to delegate in this situation? Right. Person. Does the person have the skills and qualifications? Right. Direction, communication. Have you clearly explained what to do? Right. Supervision. Evaluation. Are you following up to ensure it's done correctly? Quick tip. Make flashcards for these and quiz yourself daily. They're a hot favorite on NCLEX. Critical thinking moment. Let's say you delegate glucose monitoring to a CNA and they report a reading of 40 mg/dL but don't take action. Who's accountable? You are. Always validate and supervise the tasks you delegate. This kind of scenario is a high-priority NCLEX question, so keep it in mind. Assignments. Playing to your team's strengths. Now, let's talk about assignments. Think of assignments like building a puzzle. You need every piece to fit perfectly for the shift to run smoothly. Here's rule number 1. Safety is non-negotiable. Imagine assigning a new grad nurse to a patient with complex cardiac issues. Big red flag, right? NCLEX loves these scenarios where you have to identify unsafe assignments. Wait, what's the solution? Match tasks to skills. For example, CNAs can take vital signs, but they cannot administer medications. Know the scope of practice for every role. It's tested often. And when giving assignments, be clear. Don't say check on Mr. Smith. Instead say, measure Mr. Smith's blood pressure every 4 hours and report systolic readings over 140. Clarity is key. Time management, turning chaos into calm. Time management, this is where we turn the chaos of a shift into calm efficiency. Let me ask you, have you ever felt like there just aren't enough hours in a day? That's where prioritization comes in. Use the ABCs, airway, breathing, circulation. Always tackle the most critical needs first. Here's an example. A patient with an obstructed airway always takes priority over a patient asking for a snack. Questions like these trip up a lot of students, so practice them. Be efficient and effective. Combine tasks when you can. During morning rounds, assess your patients while checking IV sites. It saves time and ensures thorough care. And remember, delegate wisely. Tasks like bed baths or linen changes can go to CNAs, freeing you up to focus on critical responsibilities. Real-world scenario. Your shift just started and your to-do list is a mile long. How do you decide what to do first? Follow this order. Critical tasks first, like addressing chest pain. Non-urgent tasks later, like preparing discharge papers. Prioritizing care, life, and death. Decisions. All right, this is the big one. Prioritizing care. These are the kinds of decisions that can save lives, and NCLEX loves to test your ability to get it right. Let's start with the basics. Normally, you prioritize with ABCs, airway, breathing, circulation. But here's a twist. In CPR, it's say B. Compressions, airway, breathing. Don't mix them up. Now let's layer on Maslow's hierarchy of needs. Always start with physiological needs, oxygen, fluids, food, before moving on to safety or psychological needs. Here's a classic example. A patient with severe dehydration takes priority over a patient anxious about surgery. And don't forget about disaster prioritization. In emergencies, life-saving measures always come first. Delaying non-critical tasks is perfectly okay in these situations. Quick quiz. Let's practice. You're managing 4 patients. Who do you see first? A post-op patient with a BP of 88/50 and dizziness. A patient requesting pain meds for a 710 pain level. A diabetic patient with a glucose reading of 70 mg/dL. A patient ready for discharge with no urgent needs. Got your answer? It's the post-op patient with low BP and dizziness. Why? It could indicate hypovolemia or hemorrhage. Always address the most critical life-threatening conditions first. Great job if you got it right. Disasters and emergency response planning. All right, future nurses, let's buckle up for one of the most critical and high-yield topics for your NCLEX exam. Disasters and emergency response planning. Not only is this vital for passing the test, but these principles could also save lives in your career. Trust me, you don't want to miss a single point today. So, notebooks out, focus up, and let's make this session captivating and insightful. Section 1. What is a disaster? Let's start with the basics. What exactly is a disaster? A disaster, whether human-made or natural, is any event causing destruction and devastation that's too big to handle without assistance. Think of it as a call for teamwork, an emergency response on a grand scale. Here's where NCLEX likes to challenge you. Do you know the difference between internal and external disasters? Internal disasters happen inside the healthcare facility. Picture this. A fire breaks out in the hospital or there's a radiation spill. These are internal disasters. External disasters occur outside the facility, like a multi-car pileup or a natural disaster that floods the emergency department with patients. Let's take it a step further. Multi-casualty events. The hospital can handle these with the resources it has. Mass casualty events. The hospital is completely overwhelmed, requiring outside help. Mark this down. This is a favorite NCLEX topic. If you get a question about the difference, you'll ace it. Section 2. The Emergency Response Plan, ERP. Now let's talk about the backbone of disaster readiness, the Emergency Response Plan, ERP. Every healthcare facility must have a formal plan to guide staff during disasters, whether they're internal or external. Key components to remember for NCLEX include clear communication protocols, defined roles for all staff members, emergency resources, and procedures. Here's a quick question for you. What's the first step in activating the ERP? That's right, assessing the situation and notifying the necessary team members. Highlight this, it's a must-know for your exam. Section 3. The American Red Cross, ARC. Who here has heard of the American Red Cross? Did you know they have federal authority to provide free disaster relief? Here's why the ARC is important for NCLEX. They develop and test community disaster plans. They train emergency responders and educate the public on disaster preparedness. They operate shelters and provide immediate aid, including counseling during crises. As nurses, you have pivotal roles here. You might act as managers, supervisors, or educators in first aid. You could also help with disaster relief efforts, organize immunization drives, or even participate in blood collection programs. Pro tip. Expect NCLEX questions about how nurses collaborate with agencies like the ARC. Knowing this could score you easy points. Section 4. Hazmat teams. All right, let's move on to hazmat teams. These are the superheroes of hazardous material exposure. Think nuclear, biological, or chemical incidents. Who makes up these teams? Often, it's emergency department staff trained specifically for these scenarios. NCLEX loves asking about decontamination protocols. What's the first step? Remove the contaminated clothing. Pharmacological treatments. Know your antidotes for toxins. PPE, personal protective equipment. Full protective suits are a must. Remember, you'll likely get questions on how to recognize patterns of illness caused by hazardous exposures. Think big: chemical spills, radiation leaks, or bioterrorism. Know your role. Section 5. Phases of Disaster Management. Now this part is huge for NCLEX. The phases of disaster management as outlined by FEMA. There are 4 critical phases. Mitigation, actions to prevent or minimize disaster impact. Identify community risks and resources. Special focus on vulnerable populations like infants or older adults. Preparedness. Develop rescue and evacuation plans. Conduct mock drills to practice readiness. Verify emergency equipment and stockpile essential supplies. Response. Activate disaster plans. Focus on saving lives and minimizing damage. Recovery. Restore the community to normal. Prevent long-term health and economic effects. Key takeaway. Mitigation and preparedness are NCLEX favorites. Know these like the back of your hand. Section 6. Levels of Disaster. Let's break down FEMA's levels of disaster. Trust me, these classifications will show up on your exam. Level 1. Massive disaster requiring federal involvement. Think hurricanes or major earthquakes. Level 2. Moderate disaster with a federal emergency declaration. Localized flooding is a good example. Level 3. Minor disaster with minimal damage, like a small tornado that doesn't leave widespread destruction. Here's a mnemonic for you: massive, moderate, minor, level 1, 2, and 3. Got it. Section 7. Triage, your priority system. Okay, let's tackle triage. This is one of the most critical topics for NCLEX, and it often shows up in disaster scenario questions. At an accident site, patients are triaged into categories. Priority 1, red, life-threatening injuries with high survival potential. Example, a bright red pulsating leg wound. Priority 2, yellow, serious injuries but not immediately life-threatening. Example, closed head wounds. Priority 3, green, minor injuries. Example, a simple fracture or laceration. Black, deceased or non-survivable injuries. In the emergency department, triage categories shift slightly. Emergent, red. Life-threatening conditions like chest pain or trauma. Urgent, yellow. Needs treatment soon but isn't life-threatening, like an open fracture. Non-urgent, green. Stable conditions like minor sprains. Pro tip, always prioritize survivability. NCLEX loves asking about who gets care first. Section 8, Client Assessment. Lastly, let's talk about client assessment, another NCLEX favorite. Primary assessment, focus on life-threatening issues using ABCs, airway, breathing, circulation. If CPR is needed, switch to CAB. Compressions, airway, breathing. Secondary assessment, this comes after primary threats are managed. Collect data like history, vitals, and pain assessments. Quick reminder, always stabilize life-threatening issues first before diving into secondary assessments. NCLEX questions are all about prioritization. Lab values. Lab values are at the core of nursing practice. Knowing these by heart not only helps you on the NCLEX, but also in real-life clinical settings. Let's break them down with some easy mnemonics to help you remember. Potassium, 3.5 to 5.0 milliequivalents per liter. Think of bananas. A bunch typically has 3 to 5 bananas. Potassium is crucial for heart and muscle function, so high levels can cause arrhythmias while low levels lead to muscle weakness. Sodium, 135-145 mql. Imagine a can of soda costing 1.35 to 1.45. Sodium regulates fluid balance and nerve function. Hyponatremia can lead to confusion and seizures, while hypernatremia may cause dehydration. Calcium, 911 μdl. Dial 911 for emergencies. Calcium is vital for bone strength and muscle contraction. Watch out for tetany or cardiac issues with abnormal levels. Hemoglobin. Males, 13 to 18 gdl. Females, 12-16 gdl. Hemoglobin carries oxygen, so low levels indicate anemia, leading to fatigue and pallor. And don't forget white blood cells, Forsnod 11,000, E93. Think of kids aged 4 to 11. They're often sick, just like patients with low WBCs who are at risk for infection. Platelets, 150,000 to 400,000 per millimeter cubed. If platelets drop below 40,000, there's a significant risk of bleeding. Keep this critical value in mind. Critical lab values. Certain lab values indicate immediate danger and require urgent intervention. pH in the 6s, severe acidosis can impair organ function and lead to death. Potassium 6x mql, this could cause fatal cardiac arrhythmias. Administer calcium gluconate or insulin with glucose to stabilize the patient. CO260 or O260, respiratory distress signals the need for ventilatory support. Platelets, $40,000. This places the patient at a high risk for spontaneous bleeding. Neutrophils, 500, indicates severe immunosuppression. Implement neutropenic precautions immediately. Strict hand hygiene, no fresh produce or flowers, limited visitors, and protective isolation as needed. Arterial blood gases, ABGs. ABGs help us assess a patient's acid-base balance. Here are the normal ranges and their significance. pH, 7.35, 7.45. The balance between acid and base in the body. A pH below 7.35 indicates acidosis, while above 7.45 indicates alkalosis. PaCO2, 35-45 mmHg, reflects respiratory function. High levels indicate hypoventilation, while low levels suggest hyperventilation. HCO3, 22-26 mql, indicates metabolic status. Abnormal levels may point to kidney dysfunction or compensatory mechanisms. Key causes to remember: respiratory acidosis, hypoventilation, due to COPD or sedation. Respiratory alkalosis, hyperventilation caused by anxiety or pain. Metabolic acidosis, diabetic ketoacidosis or renal failure. metabolic alkalosis, excessive vomiting, or diuretic use. Pro tip: always check for compensation whether the lungs or kidneys are trying to restore balance. Safety precautions. Knowing your precautions can save lives. Here's a quick guide. Standard precautions: hand hygiene, gloves, and masks when needed. These apply to all patients. Droplet precautions for infections like pneumonia and influenza. Wear a surgical mask and use a private room if possible. Airborne precautions for TB, measles, or varicella. Use an N95 mask and a negative pressure room. Contact precautions for MRSA, VRE, or herpes. Always wear gloves and a gown. When removing PPE, remember gloves, goggles, gown, mask. And when donning PPE, start with the biggest equipment first: gown, mask, goggles, gloves. Assistive devices. Assistive devices help patients regain mobility, but correct usage is crucial. Crutches. Ensure 2-finger widths between the crutch and axilla to prevent nerve damage. 2-point gait. Move one crutch and the opposite foot together. 3-point gait. Both crutches move with the affected leg. Swing through. Gait. Move both crutches forward, then swing past them. Canes. Always hold the cane on the strong side, moving it with the weak leg for balance. Walkers. Advance the walker first, then step forward and remember, good leg goes up first, bad leg goes down first on stairs. Restraints. Restraints should always be a last resort, used only when the patient poses a danger to themselves or others. Here are the rules. Time limits vary. 1 hour for children under 9, 2 hours for ages 9 to 17, and 4 hours for adults. Monitor circulation every 15 minutes to ensure safety. Restraints require informed consent and a doctor's order within 1 hour if used in emergencies. Intravenous IV administration. Let's begin with intravenous IV administration, the fastest way to deliver medications. The effects start within 5 to 15 minutes, making it the preferred choice in emergencies like heart attacks, sepsis, or severe pain management. Why is it so fast? Because the medication is delivered directly into the bloodstream, bypassing absorption in the digestive tract. Subcutaneous, sub-Q, and intramuscular, IM administration. Next, we have subcutaneous, sub-Q, and intramuscular, IM administration. These methods are slower than IV but have specific uses. Sub-Q injections go into the fatty tissue under the skin, with medications like insulin or heparin taking 35 to 45 minutes to show effects. IM injections are delivered into muscle tissue, allowing faster absorption due to the rich blood supply. Commonly used for antibiotics, vaccines, and hormonal treatments, this route also acts in around 35 to 45 minutes. Sub-Q injection in the abdomen and IM injection in the deltoid. Ointment administration in children. Administering ear ointments in children requires attention to detail. For children under 3 years, gently pull the pinna down and back to straighten their ear canal. For children aged 3 years or older, pull the pinna up and back to open the canal. Why? The anatomy of the ear canal changes as children grow. This technique ensures the ointment or drops reach the affected area effectively. Key NCLEX medication safety tips. Every nurse must master the 5 rights of medication administration to ensure patient safety. Let's go over them. Right patient. Always confirm identity using 2 identifiers like name and date of birth. Right drug. Double-check the medication label against the prescription. Right dose. Calculate and verify the dose to prevent errors. Right route. Ensure the medication is given via the correct method, e.g. oral, IV, or IM. Right time. Administer the drug at the specified intervals for maximum effectiveness. Diabetes essentials, type 1 and 2. Let's dive into the types of diabetes and their differences. Type 1 diabetes. This is an autoimmune condition where the pancreas stops producing insulin. It's common in children and adolescents. Use the mnemonic K-KIDS and ketosis. Keep insulin nearby. They're insulin dependent. Kids. It's commonly diagnosed in young individuals. Ketosis. They're prone to diabetic ketoacidosis, DKA, when blood sugar is uncontrolled. Symptoms. Remember the 3 Ps: polyuria, excessive urination; polydipsia, increased thirst; polyphagia, excessive hunger. Management is summarized as diet, low carb and balanced, insulin, daily injections or pumps. Exercise helps reduce blood sugar and improves insulin sensitivity. Show visual, teen holding insulin, drinking water, and exercising. Type 2. Diabetes. This form is associated with obesity and sedentary lifestyles, with insulin resistance as the main issue. Use the mnemonic DAP. Diet. Focus on low-carb, high-protein meals. Activity. Aim for at least 30 minutes of exercise, 5 days a week. Pharmacology. Use oral hypoglycemics like metformin. Diabetes complications, DKA versus HHS. Complications of diabetes can be life-threatening. Diabetic ketoacidosis, DKA. Occurs in type 1 diabetes due to severe insulin deficiency. Mnemonic, DKA. Dehydration, caused by excessive urination. Ketones, present in blood and urine due to fat breakdown. Acidosis, leads to nausea, vomiting, and fruity-smelling breath. Treatment includes IV fluids to manage dehydration and regular insulin to lower blood glucose. Hyperosmolar hyperglycemic syndrome, HHS. This is seen in type 2 diabetes with blood glucose levels exceeding 600 mmol/dl but without ketone production. Symptoms include severe dehydration, flushed skin, and confusion. Treatment involves rehydration with IV fluids and insulin therapy. Hypoglycemia. Hypoglycemia, or low blood sugar, is a critical condition that occurs due to missed meals, excessive insulin, or overexertion. Symptoms: shaking and sweating, slurred speech or confusion, a rapid heart rate, and low blood pressure. Management: if the patient is alert, give 15 grams of fast-acting carbs like orange juice or glucose tablets. If unconscious, administer glucagon injection or IV dextrose in a hospital. Insulin types and timing. Understanding insulin is key to managing diabetes. Here's a breakdown. Rapid acting, e.g. Aspart, Lispro. Onset, 15 minutes, a peak, 30 minutes. Duration, 3 hours. Short acting, regular. Onset, 1 hour, peak, 2 hours. Duration, 4 hours. Intermediate acting, NPH. Onset, 6 hours. Peak, 8 hours. Duration, 12 hours. Long-acting, e.g. Glargine Detamir. Lasts 12-24 hours, taken once daily. Show visual. Insulin chart with labeled time frames. Diabetes insipidus, DI. Lastly, let's touch on diabetes insipidus, DI, which is entirely different from diabetes mellitus. It occurs due to decreased antidiuretic hormone, ADH, leading to excessive urination and thirst. Mnemonic: think of the sip in insipidus to recall thirst and dehydration. Key signs: low urine, specific gravity, 1.003 due to diluted urine. Symptoms include dehydration and excessive fluid intake. Pregnancy overview: determining the due date. To calculate the estimated due date, use the formula last menstrual period, LMP, 3 months plus 1 week. This is a simple and reliable way to predict delivery timing. Signs of pregnancy. Probable signs: Goodell's sign, softening of the cervix. Chadwick's sign, cyanosis, bluish discoloration of the cervix, often due to increased vascularity. Fundal height and fetal development. The fundus, top of the uterus, changes position as pregnancy progresses, 12 weeks. Fundus becomes palpable. 22 weeks, fundus reaches the umbilicus. 24 weeks onwards, fundal height in centimeters corresponds roughly to the weeks of gestation. Quickening. The sensation of fetal movements typically felt between 16-20 weeks. Common first trimester symptoms. Nausea. Suggest eating dry carbohydrates, such as crackers, before getting out of bed to alleviate symptoms. Avoid ibuprofen, category X. Use acetaminophen if needed. Labor and delivery. Stages of labor. Stage 1, cervical dilation. Latent phase. Cervix dilates 1-4 centimeters. Contractions are mild and irregular, 5 to 30 minutes apart. Duration may last weeks. Active phase, cervix dilates 4 to 7 cm. Contractions become more regular, 3 to 5 minutes apart. Transition phase, cervix dilates 8 to 10 cm. Contractions are intense and frequent, 2-3 minutes apart. Danger signs. Contractions lasting 90 seconds or occurring 2 minutes apart can indicate fetal hypoxia and require immediate intervention. Stages 2-4, Stage 2, delivery of the baby. Stage 3, delivery of the placenta. Stage 4, postpartum recovery and monitoring. Labor medications. Tocolytics, e.g., terbutaline. Used to slow preterm labor. Think of turbulence in a plane, we slow it down. Pitocin, oxytocin, induces labor and manages postpartum hemorrhage. Monitor for uterine hyperstimulation. Pregnancy complications. Placenta previa. Signs, painless bright red vaginal bleeding. Management, fluids, blood transfusion, and possible delivery. Placental abruption. Signs, painful dark vaginal bleeding. Management, oxygen, bed rest, and immediate delivery if needed. Preeclampsia, eclampsia. Preeclampsia, proteinuria, hypertension, and edema. Eclampsia, seizures in addition to preeclampsia symptoms. Management, seizure precautions, lie on side, oxygen, suction, padded bed rails. Administer magnesium sulfate and monitor closely. Key mnemonic for obstetric emergencies. Lion. L, lie on the side. I, increase IV fluids. O, oxygen administration. N, notify the provider. Fetal heart rate monitoring. Normal range 110-160 BPM. Bradycardia 100 BPM. Stop Pitocin and perform Lion. Fetal heart rate patterns. Veal chop mnemonic. V, variable decelerations. C, cord compression. Intervene immediately. E, early decelerations. H, head compression. Normal, monitor. A, accelerations. O, okay, reassuring. L, late decelerations. P, placental insufficiency, requires Lion. Postpartum care. Postpartum assessments. Vital signs, monitor for signs of infection or hemorrhage. Fundus. If displaced, catheterize the patient. If boggy, perform fundal massage. Perineal pads, excessive saturation, 15 minutes, indicates possible hemorrhage. Repositioning and bleeding check. Ensure patient comfort and monitor for complications. Fundal height, returns to umbilical level within 24 hours post-delivery. Fetal positioning. Preferred positions. LOA, left occiput anterior, and ROA, right occiput anterior. Risky position. OP, occiput posterior. May require knee to chest positioning and maternal pushing. Fetal station. Describes the fetal presenting part relative to the maternal ischial spine. Negative stations, above the ischial spine. Positive stations, below the ischial spine, indicating descent and progression. Failure to progress, e.g., persistent negative station, may indicate complications like cephalopelvic disproportion, CPD. Psychiatric disorders. Understanding psychiatric disorders is crucial for providing effective care. Let's explore key conditions and nursing considerations. Major depressive disorder, MDD. Symptoms: persistent sadness, lethargy, fatigue, significant weight changes, sleep disturbances, and anhedonia, loss of pleasure in usual activities. Nursing approach: establish a therapeutic relationship. Acknowledge feelings using phrases like, "I see you're feeling this way. Can you tell me more about it?" Encourage open dialogue and monitor for signs of suicidal ideation. Schizophrenia. Symptoms: hallucinations, delusions, disorganized speech, and impaired reality testing. Nursing approach: present reality gently, e.g., "I understand that you see or hear this, but I am here, and this is real." Reassure safety and focus on grounding techniques. Bipolar disorders. Bipolar I, characterized by intense mania, including excessive energy, impulsivity, and grandiosity. Bipolar II. a less severe form emphasizing depressive episodes with mild hypomania. Nursing approach. During mania, ensure patient safety, redirect excessive energy into non-harmful activities, and maintain a calm environment. Cognitive disorders. Dementia versus delirium, dementia, progressive memory loss, e.g. Alzheimer's disease. Regular orientation and memory aids can help. Delirium. Sudden confusion, often reversible and caused by infections, e.g. UTIs, fever, or medication reactions. Nursing intervention. Reassure patients experiencing delirium that it is temporary and keep them oriented to time, place, and person. Pediatrics. Tetralogy of Fallot. A congenital heart defect leading to chronic hypoxemia. Remember, VORP. V. Ventricular septal defect. O. Overriding aorta. R. Right ventricular hypertrophy. P. Pulmonary stenosis. Nursing tips. Monitor oxygen levels and prepare families for potential surgical interventions. Hyperbilirubinemia. Definition. Elevated bilirubin levels leading to jaundice. Normal range. 10-20 mcg/dL. Complications. Kernicterus, bilirubin in the brain, may cause opisthotonos, hyperextended posture. Nursing focus. Early detection and treatment using phototherapy or exchange transfusion. Developmental milestones. 1 month, grasp reflex. 4 months, rolls from front to back, begins smiling. 6 months, rolls from back to front, starts babbling, begins teething. 8 months, sits unsupported. 9 to 12 months, starts walking with support. 2 years, kicks a ball, climbs stairs. 3 years, runs, draws simple shapes. 4 years, uses scissors, pours beverages. Key consideration, development varies. Focus on earlier milestones if unsure of the timeline in questions. Safe sleep practices. Place infants supine to reduce the risk of sudden infant death syndrome, SIDS. Pain assessment, Wong-Baker faces. Scale, for children 3+ years old, FLACC. Scale, for infants 2 months to 7 years, assessing facial expression, activity, and consolability. Nutrition. For children 4 to 6 years old, slower growth can lead to physiologic anorexia. Focus on balanced meals. Half the plate, fruits and vegetables. 1/4 grains. 1/4 protein, 1 cup of dairy, medication. Administration, pediatric doses are weight-based. Pay close attention to dosage calculation questions involving children. The NCLEX is fundamentally a safety exam, emphasizing the importance of understanding drug levels, side effects, and contraindications. Below is a detailed guide to pharmacology essentials for NCLEX preparation, toxic drug levels. Lithium, used for bipolar disorder. Therapeutic range 0.6 to 1.2 mql. Toxicity, levels above 2 mql can cause tremors, metallic taste, and diarrhea. Monitor sodium levels as low sodium can increase lithium toxicity risk. Digoxin, digitalis lanoxin, used for atrial fibrillation, AFib, and heart failure. Therapeutic range 0.5 to 2 ng/ml. Toxicity, levels above 2 ng/ml. Watch for nausea, vomiting, and yellow-green halos. Theophylline, a bronchodilator for airway spasms. Therapeutic range 10 to 20 mcg/ml. Toxicity, levels above 20 mcg/ml can cause seizures and arrhythmias. Phenytoin, Dilantin, an anti-seizure medication. Therapeutic range 10 to 20 mcg/ml. Toxicity, levels above 20 mcg/ml can cause nystagmus, ataxia, and confusion. Antihypertensive medications, calcium channel blockers, e.g. amlodipine. Reduce blood pressure by blocking calcium in vascular smooth muscle. Beta blockers, e.g. metoprolol, slow the heart rate and decrease myocardial workload. ACE inhibitors, e.g. lisinopril. Relax blood vessels by inhibiting the renin-angiotensin system. ARBs, e.g. losartan, block angiotensin receptors, reducing blood pressure. Diuretics, e.g. furosemide, help eliminate excess fluid, reducing blood pressure. Psychiatric medications, key side effects, A, B, C, D, E, F, G. A. Anticholinergic effects, dry mouth, urinary retention. B. Blurred vision. C. Constipation. D. Drowsiness. E. Euphoria. F. Photosensitivity. G. Granulocytosis, low WBCs. Classes of psychiatric medications, phenothiazines, typical antipsychotics, e.g. chlorpromazine, also used as antiemetics. Tricyclic antidepressants, e.g. amitriptyline. Elevate mood by increasing norepinephrine and serotonin. SSRIs, e.g. sertraline, fluoxetine. Treat depression and anxiety. Watch for serotonin syndrome, SAD, sweating, apprehension, dizziness. MAOIs, avoid tyramine-rich foods, e.g. cheese, smoked meats, to prevent hypertensive crises. Benzodiazepines, e.g. diazepam, used for anxiety, muscle relaxation, and alcohol withdrawal. Antimicrobial medications. Penicillins and cephalosporins. Broad-spectrum antibiotics. Avoid cephalosporins if allergic to penicillin. Aminoglycosides, e.g. gentamicin, mean old mycin for severe infections. Monitor for ototoxicity and nephrotoxicity. Rifampin, used for TB, can turn body fluids orange. Monitor liver function. Vancomycin treats severe infections like MRSA. Watch for red man syndrome and hypotension. Cardiac drugs, nitroglycerin, vasodilator for angina. Administer sublingually up to 3 doses 5 minutes apart. Avoid concurrent use with erectile dysfunction medications. Warfarin, oral anticoagulant. Monitor INR 2 to 3 therapeutic. Heparin, immediate anticoagulation. Monitor APTT 1.5 2.5 times control. Epinephrine, vasopressor for shock, asthma, and anaphylaxis. IV fluids and complications. Types of IV fluids. Isotonic, normal saline 0.9%. Lactated ringers. Hypotonic, 0.45% saline, rehydrates cells. Hypertonic, 3% saline, reduces fluid overload. Complications, infiltration, edema, cool skin. Use warm compress. Extravasation, pain, necrosis. Use antidote and cold compress. Phlebitis, red streak. Use warm compress. Burns, types, superficial, red, blanchable. Partial thickness, wet, blistered, painful. Full thickness, waxy, dry, painless. Rule of nines, calculate burn extent to guide fluid resuscitation. Antidotes, warfarin, vitamin K, heparin, protamine sulfate. Acetaminophen, acetylcysteine. Opioids, naloxone, blood administration. Verify blood type with a second nurse. Administer within 30 minutes of receiving from the blood bank. Monitor for reactions, e.g. fever, chills, during the first 15 minutes. Delegation for NCLEX. LPNs cannot perform initial assessments, IV medications, or blood administration. UAPs can assist with vitals, ambulation, and hygiene, but cannot handle medications or unstable. Cardiac drugs NCLEX review, calcium channel blockers. The topic of calcium channel blockers often appears in 2-3 NCLEX questions. It is crucial to study this thoroughly without skipping any details. Calcium channel blockers function similarly to the substance Depon, as both have a calming effect on the body. Just as Depon relaxes individuals, calcium channel blockers calm the heart. It is important to note that calcium channel blockers should not be administered in certain conditions. For example, they should be avoided if a patient is experiencing shock, heart block, a condition requiring heart stimulation. However, in situations where the goal is to rest the heart, such as during a heart attack, these medications can be used. Technically, calcium channel blockers are classified as negative inotropic agents, negative chronotropic agents, negative dromotropic agents. These terms mean that calcium channel blockers calm the heart. The distinction between positive and negative inotropic, chronotropic, and dromotropic agents is essential. Positive agents strengthen and accelerate heart stimulation, classifying them as cardiac stimulants. Negative agents weaken, slow down, and depress heart activity, classifying them as cardiac depressants. Negative agents, including calcium channel blockers, are used to treat specific conditions such as small aguiole, antihypertensives, which relax the heart and blood vessels, lowering blood pressure. For high blood pressure, calming drugs like dipan or calcium channel blockers are used instead of stimulants. Anti-anginal medications. These drugs relax the heart, reduce oxygen consumption, and treat angina by decreasing oxygen demand. Calcium channel blockers are also effective in treating certain types of arrhythmias, remembered as big AAA. Anti-atrial arrhythmias such as atrial flutter, premature atrial contractions, paroxysmal atrial tachycardia, atrial fibrillation. However, they are not effective for ventricular tachycardia, as this condition involves the ventricles, which are not targeted by these drugs. Examples of calcium channel blockers include medications ending in dipine, such as amlodipine, nifedipine. Additionally, other essential calcium channel blockers are verapamil, diltiazem. Chest tube management NCLEX review. Chest tubes are a common NCLEX topic with 1 to 2 questions frequently appearing in the exam. It is important to study this topic carefully. Function of chest tubes. Chest tubes play a critical role in re-establishing negative pressure in the pleural space, which helps the lungs expand as the chest wall moves. Understanding the reasons for chest tube placement is essential for managing various conditions effectively. Conditions requiring chest tubes. Pneumothorax. The chest tube removes air, as pneumo refers to air, which creates positive pressure. Hemothorax. The chest tube removes blood, as it also causes positive pressure. Pneumohemothorax. In cases where both air and blood are present in the pleural space, the chest tube removes both to restore negative pressure. Re-establishing negative pressure is crucial for optimal lung expansion and effective breathing. Chest tubes in different scenarios enable caregivers to monitor their efficiency accurately. Location is another critical factor in chest tube management, with apical and basal placements serving different purposes. Apical chest tubes are positioned higher up and are utilized to remove air as air rises. On the other hand, basal chest tubes are placed at the bottom of the lungs and are effective in removing blood, aided by gravity. A helpful mnemonic to remember is A for apical, air, and B for basal, blood. Troubleshooting chest tubes. If a drainage device is accidentally knocked over, simply reposition it and have the patient take deep breaths. If the water seal drainage system breaks, clamp the tube immediately to prevent positive pressure from entering the pleural space. Cut away the broken tube and submerge the end in sterile water to create a seal and prevent further complications. If the chest tube gets pulled out, cover the hole with a gloved hand immediately. Use Vaseline gauze to seal the hole and prevent air from entering the pleural space. Bubbling in chest tube systems. Continuous bubbling in the water seal chamber indicates a system leak and requires immediate attention. Intermittent bubbling in the water seal chamber is normal and expected. Intermittent bubbling in the suction control chamber suggests that suction is too low and needs adjustment. Clamping chest tubes. Chest tubes should not be clamped for more than 15 seconds without a doctor's order. Always use rubber-tipped double clamps to avoid puncturing the tube. Intramuscular injections. Quiz. Question: what is the best site for intramuscular injection in an infant? Hint: share your thoughts in the comments. Congenital heart disease, CHD. Congenital heart defects are classified into 2 categories: trouble and not trouble. Mnemonic for trouble. Focus on the word trouble. Write it as trouble, with consonants capitalized and vowels in lowercase. Defects categorized as trouble shunt blood right to left, RL, and result in cyanosis, bluish discoloration. Defects categorized as not trouble shunt blood left to right, LR, and result in a non-cyanotic state, pink appearance. Examples: tetralogy of Fallot starts with T, trouble, R, L shunt, cyanotic. Ventricular septal defect, VSD, starts with V, not trouble, L, R shunt, non-cyanotic. Transposition of the great vessels starts with T, trouble, R, L shunt, cyanotic. Patent ductus arteriosus, PDA, starts with P, not trouble, L, R shunt, non-cyanotic. Intravenous, IV. Therapy. IV therapy is essential for delivering fluids, medications, and blood products. Key topics include types of IV solutions, isotonic solutions. Examples: normal saline, 0.9% NaCl, lactated ringers. Use: fluid loss, dehydration. Hypotonic solutions. Examples: 0.45% NaCl, half normal saline. Use: hydration by moving water into cells. Hypertonic solutions. Examples: 3% NaCl, dextrose, 10% in water, D10W. Use: draw water out of cells, used cautiously in emergencies. IV access types: peripheral IV. Line commonly used for short-term therapy, inserted in hand or forearm veins. Central venous access devices, CVAD. Used for long-term therapy or strong medications, e.g., PICC lines, central venous catheters. Aphootherapy complications: air embolism. Cause: air enters the vein. Signs: tachycardia, cyanosis, chest pain. Prevention: secure connections, prime lines, catheter embolism. Cause: catheter tip breaks. Signs: pain, rapid pulse, cyanosis. Action: apply a tourniquet, seek immediate medical attention. Infiltration. Cause: fluid leaks into surrounding tissue. Signs: edema, coolness, numbness. Action: stop infusion, elevate limb, use a cold pack. Phlebitis and thrombophlebitis. Cause: inflammation of the vein, often due to irritation. Signs: redness, tenderness, sluggish infusion. Prevention: rotate sites, use appropriate cannulas. Circulatory overload. Cause: rapid fluid administration. Signs: hypertension, dyspnea, moist cough. Prevention: monitor at-risk patients, regulate infusion rate. Fluid and electrolyte NCLEX Review. Balance concepts. Fluid and electrolyte balance is essential for maintaining homeostasis and ensuring the body's physiological processes function properly. This topic is a frequent area of focus on exams like NCLEX, with 3 to 4 questions typically appearing. Understanding fluid and electrolyte balance helps nurses manage patients with hydration or electrolyte imbalances effectively. Electrolytes. Electrolytes are substances that dissolve in water to form ions, which carry electrical charges. These ions are categorized into cations, positively charged ions, e.g., sodium, Na+, potassium, K+, calcium, Ca2+, magnesium, Mg2+. Anions, negatively charged ions, e.g., chloride, Cl, bicarbonate, HCO3, phosphate, PO43. Function of electrolytes: regulate nerve and muscle function, maintain acid-base balance, facilitate enzymatic reactions, control water distribution across body compartments. Measurement: electrolyte concentrations are expressed in milliequivalents per liter, MEQOL, which reflects the ion's chemical reactivity. Body fluid compartments. Body fluids are distributed across 3 primary compartments separated by selectively permeable membranes. Intravascular compartment. Fluid within blood vessels, including plasma. Helps transport nutrients, oxygen, and waste products. Intracellular compartment. Fluid inside cells, accounts for 70% of total body water. Crucial for cellular metabolism and biochemical reactions. Extracellular compartment. Fluid outside cells, further divided into interstitial fluid, fluid between cells. Plasma, liquid portion of blood. Transcellular fluid includes cerebrospinal fluid, pleural fluid, and joint fluid. Third spacing. Definition: third spacing refers to the pathological accumulation of fluid in non-functional areas such as the pericardial cavity, pleural cavity, or peritoneal cavity. Causes: trauma, inflammation, burns, or severe infections. Effects: fluid trapped in these spaces is unavailable for normal physiological processes, leading to hypovolemia despite adequate fluid intake. Symptoms: edema, decreased blood pressure, increased heart rate, and reduced urine output. Edema. Definition: edema is the abnormal accumulation of fluid in interstitial spaces. Localized edema. Restricted to a specific area, caused by trauma, burns, or localized inflammation. Generalized edema. Widespread and systemic. Associated with chronic conditions such as heart failure, kidney disease, or liver failure. Can lead to anasarca, a severe form of generalized edema involving the whole body. Body fluid composition and importance. Total body fluid. Adult, 약 60% of body weight. Older adults, 55% decreased due to reduced muscle mass and increased fat. Infants, 80%. Higher water content makes them vulnerable to fluid imbalance. Functions of body fluid, transportation of nutrients, oxygen, and waste products. Regulation of body temperature, acting as a solvent for biochemical reactions. Fluid transport mechanisms. Osmosis, movement of water across a selectively permeable membrane from lower solute concentration to higher concentration. Purpose, equalizes solute concentration on both sides of the membrane. Example, water uptake by plant roots. Diffusion, passive movement of solutes, e.g. ions, gases, from an area of high concentration to low concentration until equilibrium is reached. Example, perfume scent spreading in a room. Filtration, movement of water and solutes through a membrane driven by pressure gradients. Example, kidney filtration, where blood is filtered to form urine. Hydrostatic pressure. Hydrostatic pressure is the force exerted by a fluid due to its weight. Arterial capillaries. Hydrostatic pressure is higher, pushing water and nutrients into interstitial spaces. Venous capillaries. Osmotic pressure dominates, pulling water and waste products back into circulation. Clinical relevance. Imbalances can lead to edema or dehydration. Osmolality and solution types. Osmolality measures solute concentration in body fluids. Normal plasma. Osmolality is 270-300 bams/mg/kg. Types of solutions. Isotonic, equal solute concentration as cells. Maintains cell size. Examples, 0.9% NaCl lactated Ringer's solution. Hypotonic, lower solute concentration than cells, causes water to enter cells. Example, 0.45% NaCl. Hypertonic, higher solute concentration than cells, causes water to leave cells. Examples, 3% NaCl, D5NS. Parenteral nutrition, PN, NCLEX Review. Overview. PN provides nutrition directly through intravenous, IV, administration, bypassing the digestive system. Indications, severe GI disorders, malnutrition, post-surgical recovery. Components of PN, carbohydrates, supplied as dextrose, provide the majority of calories. Fats, provided as lipid emulsions to prevent essential fatty acid deficiency. Proteins, delivered as amino acids for tissue repair and growth. Vitamins, minerals, essential for enzymatic and metabolic functions. Types of PN administration. PPN, partial parenteral nutrition. Administered through peripheral veins for short-term use. TPN, total parenteral nutrition, administered through central veins, e.g. subclavian, jugular, for long-term use. Complications and nursing interventions. Air embolism, caused by air entering the catheter. Intervention. Position the patient on the left side with the head lower than the feet and administer oxygen. Hyperglycemia, common, due to high dextrose concentration in PN. Intervention, monitor blood glucose and administer insulin as prescribed. Hypoglycemia, caused by abrupt discontinuation of PN. Intervention, gradually taper PN and replace with a 10% dextrose solution. Infections, risk of infection due to catheter contamination or improper aseptic techniques. Intervention, remove the catheter and send it for culture. Initiate antibiotics as prescribed. Refeeding syndrome, electrolyte imbalance due to rapid initiation of nutrition in malnourished patients. Intervention, monitor potassium, magnesium, and phosphate levels closely. Diabetes Management NCLEX Review. Diabetes is a chronic condition related to glucose metabolism. Glucose serves as the primary fuel source for the body, powering essential cellular processes. However, individuals with diabetes face challenges in processing glucose. This can occur due to lack of insulin. Insulin, produced by the pancreas, helps cells absorb glucose. In its absence, glucose cannot enter the cells. Insulin resistance, in this case, cells do not respond effectively to insulin. As a result, glucose builds up in the blood, hyperglycemia, and cells are deprived of the energy they need, which can lead to cell damage and severe complications. Diabetes insipidus versus diabetes mellitus. Although both share the name diabetes, these two conditions are entirely different. 1. Diabetes insipidus. Cause: a deficiency in the hormone ADH, antidiuretic hormone, which regulates water balance in the body. Symptoms: excessive urination, polyuria; excessive thirst, polydipsia; dehydration. Key fact: diabetes insipidus is related to fluid imbalance, not glucose levels. 2. Diabetes mellitus. Cause: problems with glucose metabolism due to insulin deficiency or resistance. Symptoms: polyuria, excessive urination; polydipsia, excessive thirst; polyphagia, excessive hunger. Key difference: while both conditions involve excessive urination and thirst, diabetes mellitus also affects glucose levels, unlike diabetes insipidus. SIADH, syndrome of inappropriate antidiuretic hormone. SIADH is the opposite of diabetes insipidus. Cause: excessive secretion of ADH leading to water retention. Symptoms: reduced urine output, oliguria; lack of thirst due to fluid retention; weight gain due to water retention; urine output and blood glucose relationships; high urine output. Plus, normal glucose suggests diabetes insipidus; high urine output plus elevated glucose indicates diabetes mellitus; low urine output plus normal glucose suggests SIADH. Relationship between urine volume and specific gravity. Specific gravity refers to the concentration of solutes in the urine. The relationship is inverse: high urine output, low specific gravity; diluted urine; low urine output, high specific gravity, concentrated urine. Examples: SIADH, low urine output, high specific gravity; diabetes insipidus, high urine output, low specific gravity, nursing diagnoses; fluid volume deficit, seen in diabetes mellitus and diabetes insipidus due to excessive fluid loss; fluid volume excess, seen in SIADH due to water retention. Diabetes mellitus overview. Types of diabetes mellitus. Type 1, diabetes, and also known as insulin-dependent diabetes mellitus, IDDM, usually diagnosed in children or young adults. Requires insulin therapy as the pancreas produces little or no insulin. Type 2, diabetes, also known as non-insulin-dependent diabetes mellitus, NIDDM, common in adults and often linked to obesity and lifestyle factors. Managed with diet, oral hypoglycemic agents, and exercise. Symptoms of diabetes, the 3 Ps. Polyuria, excessive urination as the body attempts to eliminate excess glucose. Polydipsia, excessive thirst due to fluid loss from frequent urination. Polyphagia, excessive hunger caused by the body's inability to use glucose effectively. Treatment of type 1 diabetes. Diet, less rigid now, with guidance on healthy food choices. Insulin therapy, essential for controlling blood glucose levels. Exercise, helps lower blood sugar levels and improve overall health. Dietary management for type 2 diabetes. Calorie restriction, key to managing weight and blood sugar levels. Dividing meals, splitting daily calorie intake into 6 smaller meals helps prevent blood sugar spikes. Insulin overview. Types of insulin: regular insulin, short-acting, clear in appearance. Onset: 1 hour, peak 2 hours. Duration: 4 hours, suitable for IV use. NPH. Insulin, intermediate acting, cloudy in appearance. Onset: 6 hours, peak 8-10 hours, duration 12 hours. Lispro, Humalog, rapid acting. Onset: 15 minutes, peak 30 minutes, duration 3 hours. Glargine, Lantus, long-acting with no peak, duration 12-24 hours and safe for bedtime use. Practical points: rotate injection sites to avoid lipodystrophy. Fat accumulation. Store insulin properly, refrigerate unopened vials, keep opened vials at room temperature for up to 30 days. Exercise and illness in diabetes. Exercise acts like an additional dose of insulin, lowering blood sugar levels. Illness. Blood sugar levels rise due to stress on the body. Diabetics must continue insulin therapy and stay hydrated. Complications of diabetes. 1. Hypoglycemia. Causes: too much insulin, skipping meals, or excessive exercise. Symptoms: shakiness, confusion, irritability, sweating. Treatment: conscious. Provide a sugary drink or snack. Unconscious, seek emergency medical care. 2. Diabetic ketoacidosis, DKA. Who gets it? Mostly seen in type 1 diabetes. Causes: illness, missed insulin doses, overeating, or lack of exercise. Symptoms: dehydration, dry skin, weak pulse, headache. Fruity smelling breath, rapid breathing, small breathing. Treatment: IV fluids to rehydrate, regular insulin to lower glucose levels. 3. Hyperosmolar, hyperglycemic non-ketotic syndrome, HHNK. Seen in type 2 diabetes, caused by severe dehydration and high glucose levels. Long-term complications of diabetes: due to poor tissue perfusion, renal failure, stasis ulcers, gangrene. Due to peripheral neuropathy, blindness, impotence, heart disease. Lab test: hemoglobin A1C. Measures long-term glucose control. Ideal, sub on 6%. Poor control is at 8%. Borderline is 7%, requiring further investigation. 1111. ChatGPT said, ChatGPT Blood Transfusion NCLEX Review. Introduction. Blood transfusion is a critical topic for the NCLEX exam. Expect to encounter at least 1 or 2 questions on this subject in your next test. Pay attention to every detail. It could be the key to answering correctly. Types of blood components: packed red blood cells, PRBCs, used to replenish erythrocytes. A unit infuses over 2 to 4 hours. Each unit increases hemoglobin by 1 GUIDL and hematocrit by 3%. Effectiveness is gauged by anemia symptom relief and improved hemoglobin and hematocrit levels. Leukocyte-depleted units: minimized leukocytes, proteins, and plasma. Enhance oxygen carrying capacity and restore intravascular volume. Beneficial for those with prior allergic reactions or hematopoietic stem cell transplants. Washed red blood cells, devoid of plasma, platelets, and leukocytes. Recommended for individuals with severe allergic transfusion reactions. Platelet transfusion treats thrombocytopenia and platelet dysfunction. Platelet units are cross-matched, optional, and should be administered promptly within 15-30 minutes of arrival. Effectiveness is evaluated by platelet count increases, 5 naus, 10,000 AMPU3 per unit. Fresh frozen plasma, FFP. Provides clotting factors but lacks platelets. Infused within 2 hours of thawing. Success is evaluated via coagulation tests, PT, PTT. Cryoprecipitates, derived from FFP, primarily used to replenish clotting factors. Factor 8, fibrinogen. Must be used immediately after thawing and administered within 15-30 minutes. Granulocytes, treat sepsis or neutropenia with antibiotic-resistant infections. Effectiveness is monitored by WBC and differential counts. Types of blood donations. Autologous donations. Clients donate their blood for scheduled procedures. Not suitable for patients with leukemia or bacteremia. Blood salvage. Blood suction from enclosed body sites is washed to remove tissue debris before reinfusion. Designated donors. Recipients select compatible donors. Compatibility. Universal recipients. AB-positive individuals can receive blood from any type. Universal donors. O-negative individuals can donate to all blood types. RH factor. RH-positive individuals can receive RH-negative blood, but RH-negative recipients should not receive RH-positive blood. Equipment and procedures. Infusion pumps and tubing. Use specific IV tubing for blood products. Manual pressure cuffs can be used, but avoid sphygmomanometer cuffs. Blood warmers. Prevent hypothermia during transfusions. Only use approved devices. Never use microwaves or hot water. Safety measures. Verify recipient identity and blood type. Inspect blood bags for leaks, discoloration, or clots. Use 18-19 gauge needles for smooth flow. Monitoring and documentation. Always monitor vitals and lung sounds during transfusion. especially in the first 15 minutes. Document the client's response and any complications. Common complications and management. Circulatory overload, symptoms, coughing, chest pain, headache. Action, slow infusion and contact healthcare provider. Septicemia, symptoms, fever, chills, vomiting, shock. Action, stop transfusion, alert provider, and obtain blood cultures. Iron overload, common in patients with multiple transfusions. Treatment, administer deferoxamine, IV or subcutaneously. Hypocalcemia, caused by citrate binding to calcium. Symptoms, muscle spasms, tingling. Action, slow transfusion, monitor calcium levels. Hyperkalemia, older blood releases potassium. Action, use fresh blood for at-risk patients and monitor potassium levels. Citrate toxicity. Rapid transfusion can deplete calcium and magnesium. Patients with liver issues need extra caution. Additional tips. Always use normal saline with blood products. Avoid combining medications with blood components. Premedicate patients with a history of transfusion reactions. All right, let's dive into the vibrant world of nutrients, shall we? Picture this. Our body is like a high-performance engine, and nutrients are the fuel, the oil, the coolant, all the essentials that keep it running smoothly. So, let's break this down with energy, logic, and some NCLEX ready nuggets along the way. A. Carbohydrates. Carbohydrates, my friends, are the frontline soldiers of energy. They provide 4 calories per gram, making them the body's preferred energy source. Think of them as the quick-firing fuel that powers every cell in your body. What's more? They're team players. They assist in normal fat metabolism, spare proteins for muscle repair, and keep the gut in check. Your go-to sources? Milk, grains, fruits, and veggies. But here's the kicker. Inadequate carbs mean trouble, disrupted metabolism, fatigue, and energy depletion. And hey, don't forget, NCLEX loves testing carbohydrate functions, food sources, and what happens when you don't get enough. B. Fats. Now, fats are the power banks of energy, packing a punch at 9 calories per gram. Not only do they fuel you up, but they also shield your organs like little bodyguards, regulate your temperature, and help absorb fat-soluble vitamins A, D, E, and K. Talk about multitaskers. But beware, essential fatty acid deficiencies can leave you cold, prone to infections, and even disrupt reproductive health. Too much fat, though? Cue the alarms for obesity, cardiovascular diseases, and certain cancers. NCLEX loves to test whether you can tell your good fats, unsaturated, from the bad fats, saturated and trans. Know their roles, and you're golden. C. Proteins. Proteins are the builders of your body, made of amino acids and providing 4 calories per gram. They repair tissues, regulate fluid balance, and create the VIP molecules, enzymes, hormones, and antibodies. But here's the catch. Not all proteins are equal. Complete proteins, animal sources, have all essential amino acids, while incomplete proteins, plant sources, don't. What happens if you're protein deficient? Muscle wasting and severe energy loss. Remember, NCLEX questions often love to focus on complete versus incomplete proteins and the effects of deficiencies. Be ready. D. Vitamins. Vitamins are your metabolism boosters. They're like the spark plugs for carbohydrates, proteins, and fats. Fat-soluble vitamins, A, D, E, K, can be stored in the body, but too much can turn toxic. Meanwhile, water-soluble vitamins, B-complex, and C need daily replenishment since they're excreted in urine. NCLEX favorites? Vitamin A for vision, D for bones, and C for immunity. Remember these, and you'll ace those vitamin-related questions. E. Minerals and electrolytes. Think of minerals and electrolytes as the body's conductors. They ensure your cells, tissues, and bones function in harmony. Electrolytes like sodium, Na+, potassium, K+, calcium, Ka++, and magnesium, Mg++, balance fluids and keep your neuromuscular activity in sync. Deficiencies, they're a big deal, especially for hospitalized or chronically ill clients. Expect NCLEX questions that test your knowledge of electrolyte imbalances, so master those normal values. F. Water. Water, the MVP of nutrients. It's vital for every cell and makes up 60–70% of your body weight. Dehydration, it's a full-body disaster, disrupting systems from head to toe. NCLEX Pro Tip: hydration and electrolytes often go hand in hand, so stay sharp on their interconnection. Malnutrition laboratory markers. Now, when it comes to malnutrition, lab markers are your diagnostic besties. Look out for serum albumin, long-term protein status; prealbumin, short-term status; BUN, protein loss. Electrolyte levels are crucial for assessing hydration and osmolality. Don't be surprised if NCLEX throws a lab-based scenario your way, especially about albumin and prealbumin. Therapeutic diets. All right, let's switch gears to therapeutic diets. These are a hot favorite for NCLEX: clear liquid diet. Think bowel rest or post-op recovery. Examples: water, clear broth, gelatin, ice pops. NCLEX. Note: these diets are short-term and nutritionally deficient. Know when and why they're used. Full liquid diet. Everything from clear liquids plus milk, pudding, and strained soups. Long-term, add supplements. NCLEX. Note: be ready to compare this with clear liquid diets. Mechanical soft diet. For clients with chewing or swallowing issues, mashed potatoes, ground meats, and cooked veggies are your go-tos. NCLEX note: know what foods to include and exclude. Soft diet, think easy-to-digest options like pasta, canned fruits, and tender meats. NCLEX note: focus on client-specific preferences and conditions. Low-fiber diet. For IBD or bowel obstruction, stick to white bread and refined cereals while avoiding raw fruits and veggies. NCLEX note: pay attention to restrictions for gastrointestinal conditions. High fiber, high residue diet. Indication: constipation. Fiber increases stool bulk, stimulating peristalsis and reducing transit time in the colon. Irritable bowel syndrome, IBS. Alternating constipation and diarrhea can be managed as fiber normalizes bowel movements. Diverticular disease. Fiber reduces colonic pressure and prevents the formation of diverticula by softening stools. Nursing considerations. Fiber intake, 20-35 g day. Fiber retains water in the stool, increasing volume and promoting bowel regularity. Mechanism. By adding weight to the stool, fiber speeds up the passage of undigested material, preventing constipation and associated complications like hemorrhoids. Gradual introduction. Introducing fiber slowly prevents side effects like gas, bloating, and diarrhea. Adequate fluids are essential to prevent dehydration and aid in stool softening. Gas-forming foods. Foods like beans and cruciferous vegetables can worsen bloating, so these should be moderated in patients prone to discomfort. Cardiac diet. Indications: cardiovascular conditions. Atherosclerosis, diabetes, hyperlipidemia, and hypertension require dietary modifications to reduce cardiovascular strain. DASH diet, rich in potassium, calcium, and magnesium. It lowers blood pressure by counteracting the effects of sodium. It also reduces LDL cholesterol. Nursing considerations: fat and sodium. Restriction: excess saturated and trans fats increase LDL cholesterol, leading to plaque formation in arteries. Sodium contributes to water retention and hypertension. Education on DASH diet. Fruits and vegetables reduce oxidative stress, whole grains stabilize blood sugar, and low-fat dairy provides essential minerals. Lifestyle impact. The DASH diet reduces the risk of myocardial infarction and stroke. Fat-restricted diet. Indications: malabsorption. Disorders, diseases like pancreatitis or gallbladder issues impair fat digestion, leading to symptoms like steatorrhea, fatty stools. GERD. Fat delays gastric emptying, exacerbating reflux. Nursing considerations: fat restriction reduces abdominal symptoms and prevents nutrient losses from unabsorbed fats. Vitamin deficiencies. Fat-soluble vitamins A, D, E, K may need supplementation. Fecal fat test indicates malabsorption if 10% of dietary fat is excreted in stool. High-calorie, high-protein diet. Indication: essential for recovery in burns, wound healing, and chronic conditions like COPD and HIV, where catabolism increases. Nursing considerations: nutrient-dense foods. Protein supports tissue repair, while calories provide energy to spare protein for anabolic processes. Frequent snacks. Maintaining caloric intake helps prevent weight loss in hypermetabolic states. Carbohydrate-consistent diet. Indication: maintains glycemic control in diabetes mellitus, reducing complications like neuropathy and retinopathy. Prevents hypoglycemia or hyperglycemia in glucose-sensitive conditions. Nursing considerations: carb counting ensures consistent blood sugar levels. Exchange system educates patients on balancing macronutrient intake for stable glucose metabolism. Sodium-restricted diet. Indication: reduces fluid retention in hypertension, heart failure, and renal disease. Nursing considerations: restrict processed foods. High sodium levels in canned and processed items exacerbate fluid overload. Medications and salt substitutes. Salt substitutes high in potassium may be contraindicated in renal disease due to hyperkalemia risk. Protein-restricted diet. Indication: reduces nitrogenous waste in renal disease and prevents hepatic encephalopathy in liver disease. Nursing considerations: high biological value. Protein ensures adequate amino acid intake without increasing metabolic byproducts. Energy intake prevents protein breakdown for energy, sparing it for vital functions. Gluten-free diet. Indication: required for celiac disease and non-celiac gluten sensitivity, as gluten triggers autoimmune damage to the small intestine in susceptible individuals. Nursing considerations: avoid gluten sources. Wheat, barley, and rye must be eliminated. Patients should be educated on reading food labels. Vitamin deficiencies. Monitor for deficiencies in iron, folate, and vitamin B12. Renal diet. Indication: for patients with CKD, dietary modifications prevent fluid overload and hyperkalemia. Nursing considerations: monitor fluids and electrolytes, balance potassium and phosphorus intake. Excess phosphorus leads to bone demineralization. Daily weight monitoring tracks fluid retention. Potassium-modifying diet. Indication: low potassium, hyperkalemia in renal impairment. High potassium, hypokalemia from diuretics or GI losses. Nursing considerations: low potassium foods, apples, berries, and lettuce. High potassium foods, bananas, potatoes, and spinach for hypokalemia. Low purine diet. Indication: prevents uric acid accumulation in gout and uric acid kidney stones. Nursing considerations: purine restriction, avoid organ meats and shellfish. Hydration, prevents crystal formation. High iron diet. Indication: corrects anemia from iron deficiency or blood loss. Nursing considerations: iron-rich foods, meat, legumes, and leafy greens. Vitamin C, enhances iron absorption. Vegan and vegetarian diets. Nursing considerations: nutrient balance, ensure adequate B12, calcium, and omega-3s. Complementary proteins, combine grains and legumes for a complete amino acid profile. Enteral nutrition. Indication: used when oral intake is inadequate but the GI tract is functional. Nursing considerations in tube placement verification, prevents aspiration. Caloric monitoring, adjust, based on metabolic demands and patient condition. One patient making an X for consent. All right, class, let's dive into an important topic: patient consent. Imagine this: a patient can't physically write their name, maybe due to a disability, an injury, or even illiteracy. What happens then? Legally, they can make an X as their signature, but here's the catch. This must happen in the presence of two witnesses, typically healthcare professionals like a nurse and a doctor. The role of these witnesses: critical. They must ensure that the patient fully understands the procedure, is giving consent voluntarily, and isn't being forced or coerced. This process is all about protecting the patient's rights. From an NCLEX perspective, always remember, simplify explanations for patients and document every single detail, including the names and roles of the witnesses. 2. Z-Track IM injection technique. Next up, the Z-Track technique for intramuscular IM injections. This method is a game changer for reducing skin irritation, especially when giving meds like iron dextran or hydroxyzine. Here's how it works. First, pull the skin and subcutaneous tissue laterally before inserting the needle. Why? This seals the medication in the muscle, preventing it from leaking into the subcutaneous tissue, which could cause irritation or discoloration. And here's a crucial NCLEX tip. Insert the needle at a 90-degree angle and use the correct needle length, typically 1 to 1.5 inches, depending on the patient's muscle mass. One more thing, avoid massaging the site afterward. This prevents unwanted medication dispersion. 3. Fire protocol. Race and pass. Fire safety! It's a big deal, and we use the acronym RACE to remember what to do. R. Remove patients or individuals in immediate danger. A. Activate the fire alarm. C. Contain the fire by closing doors and windows. E. Extinguish or evacuate depending on the situation. And when using a fire extinguisher, follow pass, pull, aim, squeeze, sweep. Here's an NCLEX tip. Fire scenario questions always prioritize patient safety over property. For example, removing patients from danger takes precedence over extinguishing the fire. Keep that in mind. 4. Role of LVNs, LPNs. Let's talk about the role of licensed vocational nurses, LVNs, or licensed practical nurses, LPNs. They're essential to bedside care. Their responsibilities include administering meds, except IV meds in some states, wound care, vital signs, and suctioning. But here's the key. Tasks like care planning and complex decision-making, that's for RNs. From an NCLEX perspective, questions on delegation are common. Remember, LVNs, LPNs don't handle assessments or patient teaching. Always match the task to the nurse's scope of practice. 5. Bladder palpation for urinary retention. Now, on to urinary retention. If a patient can't void, what's the first thing a nurse should do? Palpate the bladder. Why? This helps determine if the bladder is distended, a common sign of retention due to anesthesia, surgery, or neurological issues. And here's your NCLEX tip. Avoid catheterization as a first step. It increases infection risk. Instead, try non-invasive measures first, like helping the patient into a comfortable position or using natural voiding techniques like running water. 6. Using a cane. Proper technique. All right, mobility aids. When using a cane, the patient should carry it on the unaffected side and move it forward with the affected leg. Why? This ensures proper weight distribution and stability, reducing the risk of falls. For NCLEX, remember, the cane's height should allow the elbow to bend slightly 15 to 20 degrees. Teach patients to place the cane 6 inches ahead with each step for balance. 7. Crutch. Fitting for a supine patient. Let's talk about crutches. For a supine patient, measure from the axilla to the sole and add 2 inches. This clearance prevents pressure on the brachial plexus, which could lead to crutch palsy. Here's a hot NCLEX question. Where should the patient bear their weight? On their hands, not their axillae. And remember to reinforce the tripod stance for stability. 8. Initial assessment in nursing. Assessment. This is the foundation of nursing care. It starts the moment you meet the patient. You'll gather subjective data, what the patient tells you, and objective data, physical exam findings. This step is crucial for identifying priorities, especially life-threatening issues like airway or breathing problems. NCLEX loves prioritization questions here. Always document accurately and communicate your findings effectively to the healthcare team. Number 9. Insulin injection. Needle size. Here's a quick one. For insulin injections, the recommended needle size is 25 gauge and 5/8 inches long. This ensures the medication reaches the subcutaneous tissue, not the muscle. And an NCLEX tip, teach patients to choose the injection angle, 45 or 90 degrees, based on their fat layer. Also rotate sites to avoid complications like lipodystrophy. 10. Residual urine. Let's talk about residual urine, the amount left in the bladder after voiding. If it's over 100 millibars, it may indicate incomplete emptying, possibly due to an enlarged prostate or weak bladder muscles. This can lead to infections or bladder overdistension. NCLEX tip, use a bladder scanner first before catheterizing. This minimizes infection risk. 11. The nursing process. Lastly, the nursing process. It's a cornerstone of nursing care. There are 5 stages. Assessment, collect data. Nursing diagnosis, identify health issues. Planning, set goals and interventions. Implementation, execute the care plan. Evaluation. Determine if goals were met. 12. Hand washing as the best method to limit microorganism. Spread. Class, let's start with one of the most fundamental practices in infection control, hand washing. Did you know it's the single best way to prevent the spread of microorganisms? When we wash our hands, we mechanically remove bacteria, viruses, and even spores, making it a powerful defense against healthcare-associated infections, or HAIs. Now, while alcohol-based sanitizers are effective against most pathogens, they don't work on spores such as Clostridioides difficile. From an NCLEX perspective, it's critical to teach patients and their families the importance of proper hand hygiene, especially before eating or after using the restroom. Doing so significantly reduces infection risks, particularly in hospital settings. 13. Blood refusal by Jehovah's Witnesses. Next, let's discuss a key cultural consideration in healthcare. Jehovah's Witnesses believe they should not receive blood or its components, such as red cells, white cells, plasma, or platelets. This belief stems from their interpretation of biblical scriptures. However, many are open to alternatives like erythropoietin, blood salvage techniques, or volume expanders. As nurses, it's our duty to respect their beliefs while ensuring their medical needs are met. NCLEX often tests on ethical care and patient autonomy, so always assess their preferences and explore safe, acceptable alternatives. Open communication is vital in these scenarios. 14. Testing visual acuity. Let's talk about visual acuity testing, an essential part of a physical exam. To check a patient's vision, we ask them to cover one eye at a time. Why? This isolates each eye to detect problems like amblyopia, cataracts, or optic nerve damage. You'll record the results as a fraction, such as 20/20, which measures the patient's ability to see clearly at a distance of 20 feet. Here's an NCLEX tip. Always note whether the patient is wearing corrective lenses during the test, as it can impact the results. 15. Pain assessment before administering PRN medication. Before giving as-needed pain medication, it's crucial to assess the pain thoroughly. This means asking the patient to locate the pain and describe its characteristics. Did you know pain can be somatic, visceral, or neuropathic? Each type requires different treatments. For instance, somatic pain responds well to NSAIDs, while neuropathic pain often requires anticonvulsants or antidepressants. Here's a great NCLEX framework for pain assessment, the PQRST method. P. Provocation. What causes the pain? Q. Quality. What does it feel like? R. Region. Where is the pain located? S. Severity. How bad is it? T. Timing. When does it occur? Always document this information before giving any medication. 16. Distance vision testing. To test distance vision, we use the Snellen chart. The patient should stand 20 feet away as the chart is calibrated for this distance. This allows us to accurately measure and compare their vision to the standard of normal vision. If the patient cannot stand 20 feet away, adjustments can be made proportionally, such as halving the distance. Here's an NCLEX tip. Make sure the room is well lit, free of distractions, and that the patient wears corrective lenses if prescribed. And don't forget, always document whether they use their glasses or not. 17. Oral care for an unconscious patient. Providing oral care for unconscious patients requires special precautions. Always position the patient on their side to prevent secretions from pooling in the pharynx, which could lead to aspiration pneumonia or airway obstruction. Use a soft toothbrush or foam-tipped swab and a suction device to safely remove fluids. From an NCLEX perspective, questions often focus on patient safety. Always prioritize airway patency and infection prevention during oral care. 18. Ideal room temperature for geriatric or extremely ill patients. Older adults and critically ill patients are more sensitive to temperature changes due to impaired thermoregulation. Maintaining a room temperature between 66 degrees and 76 degrees is ideal to keep them comfortable and prevent complications like hypothermia or hyperthermia. If needed, provide additional warming measures like blankets or socks, or cooling measures like fans. Here's a tip. NCLEX frequently tests on ensuring patient comfort and monitoring body temperature in vulnerable populations. Petechiae are tiny, round, purplish-red spots you might see on the skin, or mucous membranes. They happen because of intradermal or submucosal hemorrhage, basically capillaries rupture, and blood leaks out. Common causes include thrombocytopenia, low platelet count, vitamin C deficiency, scurvy, trauma, infections like meningococcemia. NCLEX. Tip: whenever you see petechiae, think of serious conditions like DIC, disseminated intravascular coagulation, or leukemia. Always document details, size, location, and whether it's spreading. These are the types of assessment questions that NCLEX loves. 20. Electrolytes. Electrolytes are measured in MEQL and are crucial for the body's functions. Let's focus on three key players. Sodium, Na+, maintains fluid balance. Normal range, 135-145 MEQL. Potassium, K+, regulates nerve impulses and muscle contraction. Normal range, 3.5-5.0 MEQL. Calcium, Ka++, important for bone health and clotting. Normal range, 8.5-10.5 nausing DL. NCLEX tip: know these ranges. Questions often test clinical implications. For example, hyperkalemia leads to cardiac arrhythmias. Hypocalcemia causes muscle spasms and may show Trousseau's or Chvostek's signs. 21. Homan's sign. A positive Homan's sign might indicate thrombophlebitis, pain in the calf during dorsiflexion of the foot. This could mean a clot is forming in the deep veins, and however, the test is not very reliable because of its low sensitivity and specificity. NCLEX tip: avoid assessing Homan's sign if DVT is suspected. It could dislodge a clot and cause a pulmonary embolism. Instead, prioritize diagnostics like Doppler ultrasound or D-dimer assays. 22. Dietary fiber. Fiber, or roughage, plays a vital role in digestive health and comes in two types. Soluble fiber lowers cholesterol and blood sugar, found in oats and fruits. Insoluble fiber adds bulk to stool and prevents constipation, found in whole grains and vegetables. NCLEX tip: educate patients to increase fiber intake gradually and stay hydrated to avoid bloating. This is a popular patient teaching question. 23. Purpura. Purpura are larger purple spots on the skin caused by blood leaking into tissues. They're bigger than petechiae, 3 millimeters, and may signal serious issues like vasculitis, thrombocytopenia. NCLEX tip: know how to differentiate purpura, petechiae, and ecchymosis by size. Look out for systemic symptoms like fever or joint pain. These could indicate Henoch-Schönlein purpura. 24. Basal metabolic rate, BMR. BMR is the energy your body needs to keep vital functions like breathing and circulation going while at rest. It's measured in kcal/kg hour under specific conditions: fasting for 14 to 18 hours, resting in a thermoneutral environment. NCLEX tip: BMR is lower in older adults and higher in males. Hypothyroidism decreases BMR while hyperthyroidism increases it. This often appears in metabolic disorder questions. 25. Needle safety. The CDC standard precautions strongly advise against recapping needles after use because it increases the risk of needle stick injuries. Dispose of needles directly into sharps containers. If absolutely necessary, use the one-handed scoop technique. NCLEX tip: expect questions on needle stick protocols and bloodborne pathogen risks. Always follow institutional policies. 26. Metabolism. Metabolism has two phases. Anabolism builds larger molecules like proteins from smaller ones for growth and repair. Uses energy, ATP. Catabolism breaks down molecules like glycogen into glucose for energy. NCLEX tip: disorders like hyperthyroidism increase catabolism, leading to weight loss. Be ready for case scenarios on these disruptions. 27. Alcohol metabolism. Alcohol is primarily metabolized in the liver by enzymes like alcohol dehydrogenase, converting it into acetic acid. Chronic alcohol use can overwhelm the liver, causing conditions like fatty liver, hepatitis, cirrhosis. NCLEX tip: Monitor patients for signs of liver damage, such as jaundice or elevated liver enzymes, and educate them on the dangers of continued alcohol consumption.